Let's call this meeting to order. Which commissioners are on the webcast?
Paul Fronston.
Hi, Paul.
Hi.
And Philip.
Hi, Fran. Okay. Let's go to agenda item number 1, approval of minutes. Included in your packets are copies of the minutes from the March 17th meeting of the Commission. If there are no changes or corrections, I'll entertain a motion to approve. Second. Any discussion? All in favor?
Mr. Chair, this is Fran. I just want to point out that I was out of the country, so I was not amongst the attendees at last month's meeting.
Okay, we will adjust the minutes appropriately. Thank you, Fran.
Thank you.
All right, minutes approved with amendment. Second agenda item is the update of activities. Commissioners, you've received the written updates. Ben, do you or any of the center directors have anything to add?
Thank you, Mr. Chairman. I had a couple updates I wanted to point out to you. These largely relate to collaborations the Commission has established. In your material is a letter of intent to the Patient-Centered Outcomes Research Institute, PCORI, that the Commission put together in consultation with researchers at the University of Maryland School of Medicine, Lorien Health, and CRISP. We submitted this letter of intent to PCORI to propose a study comparing the effectiveness of 2 evidence-based interventions for seniors discharged to skilled nursing facilities. Specifically, the study looks at the effectiveness of telehealth, transitional care versus community care teams as successful interventions in terms of treating vulnerable populations in SNF-based facilities. This is work that the Commission took on itself, brought the teams together. David Sharp and his team in the Center for Health IT and Innovative Care Delivery did this work on their own. I want to recognize David, Justine Springer, Angela Evet, Lynn Bizio, and thank them for all of their work in getting this started. We're looking forward to working with the team to submit a proposal in early June. Just for everyone's information, submitting a letter of intent and getting it accepted by PCORI is not a simple task. And although many people seek to do that, it's my understanding that only about 1 in 10 letters of intent get accepted. Once you're over that hurdle, there's about 1 in 5 chance that you ultimately will be funded. So it's a very challenging stage process. It also, I think, demonstrates the importance of some of the health IT telehealth grants that we've put in place over the last several years, because this particular application has as its foundation the work we did originally with Lorien Health and Upper Chesapeake 3 or 4 years ago. Secondly, the Healthcare Commission is starting to work with Maryland physicians, including our own Dr. Pollack, MedChi, and the St. Louis Business Group on Health on a continuing medical education course to educate primary care physicians on appropriate use of imaging in patients that present with low back pain. The goal is to educate primary care physicians not only on the appropriateness, but also on the cost associated with inappropriate imaging. The St. Louis Business Group on Health has had considerable experience in using claims data and examining cost of imaging. And it also is a mentor organization for the Healthcare Commission in our grant with the Network for Regional Healthcare Improvement that we've had for about a year now. Also wanted to make sure everyone knew that next week we will take 2 contracts to the Board of Public Works in Maryland. That is the organization that improves contracts with values above $200,000. The first is the contract with Social and Scientific Systems to continue operation and development of the medical care database. And in a separate action, we'll also seek approval from the board to award a consulting contract with Healthcare Incentive Improvement Institute, that's the Francois de Brandis organization. HCI 3 has taken the lead nationally in advocating for greater price transparency. And under that contract, we're going to get some assistance from Francois and his team on how to use Prometheus, their episode grouper. These days, everything seems like a Promethean task, so perhaps it's appropriately named. But that work is being funded through our Cycle 4 grant with Societal for rate review, so it will be all on federal money. Lastly, on a happy note, we were informed last week by AHRQ that they intend to continue to support the Monarch software through 2017. They had originally signaled that they would cease direct support in at the end of 2016. AHRQ has reaffirmed its commitment to move Monarch to an open source environment, which would enable states, including Maryland, to make modifications directly. We also would anticipate that, like many open source products, that it's very likely that a private vendor would take this over and maintain it, obviously at some cost, but nonetheless, I think it's some potential benefit for all users of Monarch today. So I think that's a very positive step forward. It'll allow us to evolve the Monarch product in a more staged and controlled manner.
So this is Commissioner Stollenberg. I just wanted to mention that being very close to the process with ARC and with the Monarch project, the work that Maryland has done, and specifically the Maryland Healthcare Commission has done in the use of Monarch and the expansion of the reporting, the public reporting, not only has been used as, frankly, a role model for other states, and other states have adopted Monarch because of seeing what Maryland has been able to do, but I think it also really opened the eyes of some of the leaders at ARC to understand what can be done with Monarch. So I would turn it around and give kudos to the staff here because of the great work you've done with Monarch. You really had a very positive impact on the decision that ARC made.
Thank you. And continuing with that, I would also mention that we are putting a small contract announcement forward to search for some consulting assistance that can enable us to expand our consumer outreach on the quality tools broadly. We'll keep you informed on that.
Thanks, Ben. Any center directors have anything to share? Paul?
So I'm pleased to announce that our center has a new program manager, Dr. Ause Amasialu. He most recently worked for the Armed Forces Health Surveillance Center, where he was a senior managing epidemiologist and the Preventative Medicine Residency Education Coordinator. Prior to that, he worked in New York State for over 10 years as an infectious disease epidemiologist and an addiction prevention research scientist. He trained internationally as a physician and is certified by the U.S. Commission for Foreign Medical Graduates. He also completed his master's in public health at Tulane University. So please join me in welcoming Ause.
Welcome. Okay, let's move to agenda item number 3. As you recall, at last month's commission meeting, Linda Cole provided an update to the Commission on plans to implement the State Health Plan chapter for hospice services. And there were a number of questions that we committed to addressing in this month's meeting. And so today, Ms. Cole will address these questions regarding the use of hospice services, as well as the methodology for determining need in the hospice chapter of the State Health Plan. Linda?
Thank you. Good afternoon, Mr. Chairman, Commissioners. As Dr. Tanio mentioned, I'm returning to you with a follow-up to last month's meeting where several questions were raised. And in your packets, you also have this written report that also addresses these in more detail. One issue relates to the availability, accessibility of hospice services to residents of Maryland. The two major questions are, where are hospices authorized to provide care, and where do they actually serve residents? A second set of issues includes the state health plan promulgation process and how regulations are developed and how that leads into the publication of the CON review schedule. Part of the promulgation process includes development of need projection methodology. Questions were raised on how unmet need is identified. And finally, there were questions on use of hospice by race, particularly African American patients, and how use varies between urban and rural areas. So I will try to briefly address these issues. First, where are hospices authorized to provide care? Each of the 24 jurisdictions in Maryland is served by at least one authorized general hospice. Authorization refers to CON approval, or for those who predate CON, grandfathering. I realize this is difficult to read on the screen, but it's also included in your report as Table 1A. As can be seen in Slide 4, 14 jurisdictions are served by a single provider. In 12, there is just one authorized provider, and in 2 additional jurisdictions, Talbot and Washington, there are 2 authorized providers, but effectively only one serves the jurisdiction. As would be expected, the single provider jurisdictions also have small population size. The second part of the question is, when hospices have authorization, where do they provide care? There were 7 hospices which provided services to fewer than 10 clients in one of their authorized jurisdictions. And again, this is included in your report, but as seen in Slide 6, most hospices served their authorized jurisdictions. However, as this table shows, there were 17 instances where jurisdictions have at least one provider with no substantial level of service offered. In most cases, this is a single jurisdiction, so 4 out of 5 served. But in the case of community hospice, 2 of 8 jurisdictions were served, and in the case of Joseph Ritchie, 2 of 7 were served. There were questions raised about the state health plan and CON, so I will try to review this briefly. Plan development and plan implementation represent an integrated 2-step process. First, the relevant chapter of the state health plan, in this case Comar 102413, which governs hospice, is developed and adopted. As I explained last month, this was a very long and inclusive process that included multiple work group meetings, briefings at the Senate Finance Committee, and multiple public comment periods. Both the proposed permanent regulations and the final regulations were presented to you for adoption, and the final regulations became effective in October of 2013. Once a plan chapter becomes effective, there is usually an immediate publication of need projections. Based on where need is identified, the jurisdiction or the region, staff publishes a schedule in the Maryland Register to alert providers as to when and where applications can be filed. There have also been several delays in implementation of this chapter. After the final regulations became effective in 2013, based on comments received, the CON review schedule was delayed until 2015. Then there was legislation introduced in 2014, which was later withdrawn, and the schedule was delayed until 2016 under an agreement reached with the chairs of the Health, Government Operations, and the Senate Finance Committees. We're now ready after 3 years to move ahead with implementation. Another area that seemed to cause some confusion is to how unmet need is determined. An element of the state health plan chapter is the hospice need methodology. Since it is a component of the regulation, its steps, the sources of data used, and the assumptions must be followed exactly as specified. This aspirational approach was first recommended by the Hospice Network, and the detailed assumptions were worked out in hospice work group meetings. There are several steps to the methodology, but basically it works as follows, and each step is done on a jurisdictional basis. First, a base year death rate is calculated by dividing the base year population deaths, and this is 35 and over, by the base year household population, again, 35 and over. The target year deaths are forecasted by multiplying this death rate by the target year household population, same age group, 35 and over. The target year gross need or potential use is determined by multiplying the target year use rate, which we discussed as the MedPAC rate, 47.3%, by the target year population deaths identified above. Going back to actual use or hospice deaths, a compound annual growth rate is calculated based on hospice deaths in the base year and the previous 5 years, and then this growth rate factor is extrapolated going forward 5 years to predict target year capacity or projected use. Target year net need is calculated by subtracting target year capacity or projected use from target year gross need or potential use by jurisdiction. And if the net need exceeds the volume threshold, which is 359, there is unmet need. And unmet need has been identified under this formula in Baltimore City and Prince George's County. This methodology has several strengths and weaknesses. In terms of strengths, it is advocated by the Hospice Network. It recognizes the unique nature of hospice. It recognizes that in hospice, no use rate is too high because we are trying to encourage the use of services. It's unknown what the target use should be, but MedPAC is recognized as a standard data source covering the Medicare population and is updated annually. It has some negatives. It uses a standard statewide volume threshold that's used across all jurisdictions regardless of size. It uses a standardized death rate that's not adjusted for age or race. And it may not project need in areas with a small population base. However, in terms of current hospice providers, there are some protections. First, because it uses a compound annual growth rate based on hospice deaths served, it assumes growth and factors in growth by current providers. Also, by providing a volume threshold, we would not invite docketing of new hospice providers if a very small need or a need under 359 were identified that could be absorbed by existing providers. Some questions also focused on hospice use by race, specifically African American patients. This is a national debate as evidenced by a recent issue of the Journal of Palliative Care Medicine devoted entirely to palliative and end-of-life issues for African Americans. We are pleased to see the progress in education and outreach as reported by the hospices in their correspondence sent to the Commission, and we commend their ongoing efforts. It is good to see that the development work surrounding this plan has spurred on a broad range of education and outreach that is expected to continue. Slide 9 indicates the proportion of hospice patients served by race and how it varies by jurisdiction and, as would be expected, varies by the proportion of the population who are African American. The total 35 and over population and the jurisdictional use rates are also included to provide a context. A final issue raised deals with lower utilization seen across areas such as Western Maryland and the Eastern Shore. Although Maryland is more urban than many states, this national data from MedPAC shows differences in urban-rural use rates. Although there has been an increase from 2000 to 2014 in both urban and rural areas, the rural rates still lag behind the urban use rates. The footnote on the bottom indicates how areas are classified in Maryland, and it should be noted that most of Maryland is classified as urban or micropolitan, and only 3 jurisdictions are considered rural adjacent to urban, and those are Caroline, Garrett, and Kent. The next step involves the publishing of hospice need projections in the Maryland Register and then developing and publishing a CON review schedule. While we recognize the concerns of existing hospices with the implementation of the plan chapter, the initiation of CON review in 2 jurisdictions does not diminish the positive efforts of existing hospices to provide good care to the patients. Although the use of hospice services is growing, the application of an aspirational methodology, as recommended by the network, continues to show unmet need in Prince George's County and Baltimore City. It should be noted that in addition to new providers, existing hospices, which are not currently authorized to serve those jurisdictions, also have the opportunity to apply during the CON process. The implementation of the plan chapter is an integral component of the regulatory process and is intended to fully serve the expanding need for hospice services. That concludes my presentation. I'd be happy to answer any questions.
Okay. Let me just sort of frame the context. So the last commission discussion, there was a lot of interest in what the gaps actually were, and people wanted to have additional data to really to come to informed perspectives. The commission has also gotten a fair amount of sort of external perspectives from a variety of stakeholders, which is appreciated. And so I think it's really important to have an open and informed discussion here. There's not an action item on the agenda because just with no action, the state health plan will continue to be implemented. But let me just start off with a question in your detailed report on page 4. Kind of you talk about that Baltimore City and Prince George's would be the only jurisdictions identified as consideration of changes, and that's really because of the threshold, the volume threshold. Mm-hmm. And so just can you play out how that would work sort of practically, because it does sound like there could be several rural counties in which there's a persistent and enduring gap, but because it doesn't hit the volume threshold, it would never sort of reach the trigger. So can you give us the context for how that is sort of methodology was derived at?
The volume threshold, as a component of the methodology, and this was again something that was discussed in the work group, whether it should be jurisdictional, whether there should be regional. There's one volume threshold. It's calculated as the median of hospice deaths, which is really a measure of utilization, the median of hospice deaths in the base year. So in this case, it's 2014. And that median number of deaths was 359. That's a negative of the methodology. It wouldn't show need in an area that may have a need for 30 patients, some of the smaller rural areas.
Yeah, but I'm correct in assuming that you could have persistent gaps, and as long as they're under the volume threshold, and that nothing would get triggered.
The assumption of the volume threshold is that a small gap in services can be absorbed by existing providers. Right. So it's different than a bed need methodology, which may say there's need for 100 more beds.
I just want to clarify. Let's just go around. Sure, absolutely.
How is that locked in stone, or is it just a general purchase agreement?
The volume threshold?
Yeah. Because it could be moved up or down.
Right. As I explained, the steps in the methodology are a component of the regulation. So those are in regulation, and unless the regulation is changed, that's it. The number itself will change as we collect 2015 data. It will be a different median number of deaths served, but it is calculated under this formula as the median number of deaths.
I guess I'm also interested in the idea of need. Why is that median number of deaths, not hospice deaths?
I'm sorry, hospice deaths.
That's right. You use hospice deaths. I'm wondering why it's not total deaths over 35. Because if you had something that was totally unserved, you would just never see never get on the radar.
The hospice deaths are actual utilization of hospice services. Population deaths, there are many deaths in the population which may be a young person, an accident, a motor vehicle accident, that wouldn't be appropriate for hospice use. So not all deaths are going to be hospice deaths.
You never serve an area you never trigger. And we certainly have some counties that there doesn't seem to be very much service.
It's a use rate of, yes, hospice
but in
deaths.
terms of a later or better generation, we could probably kick it out and throw out the car accidents and the gun deaths. And, that short list of things you really think. Yeah. It's unreasonable to ask a hospice provider to have any participation.
Yeah, definitely capture that in the minutes as a potential improvement. Yeah. Are there, Dr. Thomas?
So I can think of no more sensitive topic in the whole area of health than this, because it deals with death and death of a loved one. and I had the opportunity to spend some time with you when we did the workshops. I was at the Prince George's County workshop. I know you did one also in Baltimore. So let's just take a look at the big picture. The big picture is those two jurisdictions, for whatever reason, that are not being served. And yet, once we kind of kicked off this fact-finding and kind of shining the light, and things started to happen. Behavior changed. And I think it's significant that we could kick into motion simply by asking the question and engaging the community that organizational change started to happen. And I'm wondering to what extent you believe that can continue, that change was not just flavor of the moment, but actually a recognition by the organizations that are here that we can do a better job and we will do a better job, and they actually showed some evidence of moving the needle a little bit. Can that be sustained, in your opinion?
Well, based on the letters that you have received and all the correspondence that was sent from the hospices in response to your question at the last meeting, they all indicated that they have invested resources and do plan to continue to move forward with this.
Now, it should be noted this is a problem across the country. Everybody's doing the greatest job about it, and that the theme issue of palliative care, the entire issue of the journal, totally focused on this issue of hospice and African Americans, is very significant. I would encourage all my commissioners to scan and take a look at that. And it's in that context that the work done here in the state of Maryland could be a way to find best practices around the country. I just want to thank you for your work in helping to spearhead some of these efforts. And I don't know if the commission, once we're done with our deliberations, simply move on to other things, or if this kind of soft pressure, simply by asking the question, can stay on, again, in helping organizations move forward in organizational change on this topic.
I do have a number of questions. Oh, I'm sorry. Good. Okay, and one is just a clarification in terms of where our jurisdiction is on this sort of stuff. Is it only need, or is it also choice and quality and competition, things like that? Or are we really only dealing with need, and anything beyond that is the purview of the legislative branch and the governor?
So I think what we are looking at right now is to look at going forward within the context of the state health plan that exists. Could we recast this, as I think Commissioner Thomas has suggested, in an update of the state health plan and include other factors? Yes, we could look at it in a different way. In earlier iterations of the draft state health plan for hospice services, we did look at concepts like consumer choice, which have permeated through other chapters, most recently home health services. But given concern among existing agencies and other stakeholders, we opted for this, which I would say is a compromise methodology. Many of the elements were passed through the network and met approval back in 2013 as a way to move forward. So what I would suggest is, yes, we can look at that. Every 5 years, we are to update plans as appropriate. We're now in year 3 of a plan that yet has not really been executed. So I wouldn't want to go back and start over without at least trying to address, I think, some clear-cut gaps where we have them, recognizing that in other smaller regions of the state, we need to bring together all the stakeholders and talk about how this could work.
Okay. Yeah, I only bring it up, and I certainly don't, I understand this is a lot of work you've been
going on with this for quite a long time, and I have no desire to be the skunk at the picnic on this one. I just want to, while the window's still open, I want to at least ask a few questions about how.
I just want to add to what Ben mentioned, that in terms of quality, we did include standards in the plan to measure quality.
Good.
And as I mentioned last month, quality measurement in hospice is just at the starting stage in terms of the hospice items set and hospice caps. But once that is implemented, we will be able to incorporate that.
Okay, good. I'm still stuck a little bit, and thank you very much for this data and the report. I thought it was excellent. But it's kind of the enigma of Western Maryland. And just looking at those counties and kind of going through there. So what we see is that it looks like, to me, like we have like the highest and the lowest kind of penetration rate, you know, that Washington County is at 0.57, and our MedPAC, you know, gold standard was 0.47. So, and I'm not seeing any of the other counties that have been able to hit 0.57. So, I mean, last time I was sort of asking, you know, I mean, we have a very diverse state. Is there sort of some cultural reason or whatever that an Appalachian culture would be not as hospice prone as a shoreline beach culture or a downtown Baltimore culture? And that doesn't seem to be the case from the rates in Washington County. At the same time, we do see kind of two counties there that are also, if not the lowest, pretty rock bottom. I think they are the lowest in both Allegheny and Garrett. So I guess I had two questions. One is, how open is this system to, if there were Pennsylvania or West Virginia hospice providers, is there any barrier to their entry into these markets if they're sort of unserved? And right now the current providers of services, I mean, some of them are really low, like, you know, 100 people a year, which is hard to just think what the business plan is on serving 100 people a year. So are there barriers to entry from other hospice providers who might want to serve these counties?
Yes, you have to be a licensed Maryland provider to provide services here, unless there is a certificate of need process, and if you are a provider in Pennsylvania, you want to apply to become a Maryland hospice provider.
So they'd have to apply, but other than that, they don't have to have their headquarters located in Maryland or anything. Okay. The other thing that I want to say, and this is just speculation, and so just take it as that in terms of when we were doing the design work on so you have these things that there are clearly counties that plans want to participate in, and they seem to do quite a good job in those counties. And then there's other counties that are underserved and sort of, and there's probably really a need there, but there's not an infrastructure, there's not an interest in moving in. So when we were designing both the regional for the bids in the Medicare drug benefit as well as the PPO bids, there was a notion there, and I don't know whether that's, I mean, you've got administration, you know, you talk about jurisdictions, and they're basically counties, and then Baltimore is its own, as far as I could tell. So you have that sort of a thing. What we did there was we knew that some markets were more attractive than others. So to use the example of, and I don't mean to offend anyone from any of those states, but the insurers wanted Minnesota. It's a good market. And so what the feds did in that case, and I was one of those feds, is we said, you got to take the Dakotas, which Dakota people, nobody really wanted the Dakotas. And so the idea was, if you want Minneapolis, you got to pick up Fargo. You know, you have to do both. So what I'm not seeing here is there's clearly, as we think about these jurisdictions and how these jurisdictions are drawn, is that, again, to my question, is that something we weigh in, the legislature weighs in, we make recommendations? I can certainly see some plans that would say, all right, you would get to critical mass of hospice cases, so a provider would not lose their shirt. You know, there's like a real market here for them, which they're doing good work, and nobody goes into hospice, I assume, to make millions. You do it because it's good work. But there's a notion here of, if we have these underserved areas, which seem from the years of data you've shown are kind of chronically uninsured, or not uninsured, chronically underserved, that we're in a situation where, with some thinking about kind of how you do kind of mimic if you want Minneapolis, you have to pick up Fargo and Bismarck, kind of a...
In some areas of planning, we have done a regional approach. So, like, serve all of Western Maryland, or serve Southern Maryland and include these counties. It's still a business decision as to what parts of...
Well, that's what I'm saying. You're changing the business decision. You can't pick this county, but now, and I got that. And your memo is excellent. So I got that you're sort of told how, and so I want to do this county, I want to do this county, I want to play here. I think I want to play here, but boy, I didn't end up getting anybody. We all understand how that sort of works. I'm sort of saying that part of the nudge here is to say if you want the county that is good and lucrative and all up and running, I'm afraid next round you've got to also take the one that is a little barren right now and develop it. That's the trade-off. You get the high profit county by picking up the one that may eventually be high profit, but is not so much right now.
I think it's a very interesting idea because I do think, connecting to the initial question and your observation of the data, when you look at Allegheny and Garrett, you can see 7 years worth of data that shows that those low rates are not really changing, and that with the volume thresholds, really nothing is going to change under the existing system. And so what I would say is that I think that the methodology that was really done off of lots of well-intentioned hard work on both sides, and kind of is what it is at this point. But now we can also see some of the upsides and the downsides of where we are, and we should absolutely capture that for future iterations. Dr. Thomas?
Yeah, just very briefly, my friend. I wonder if the hospice is really a different market. It's really uniquely, potentially different, largely because of its origins. In the early days of, when people had cancer, I knew and I could tell you with some precision,
right,
you got 4 months. And things have really, really changed. And I wonder if we're still in the phase of developing both the measures necessary to define this market. I don't know if it's immature or mature, but it's definitely different.
Mm-hmm.
And some of the examples, may not overlay the same way.
I think you're probably absolutely right on that, and there may be certain providers who are better at making those changes and moving it. If you take a look at the data provided, Washington County was at 30%. It was not quite as bad as the other Western Maryland, but now it's the leading in the state over this, 6 or 7 year period. So change can happen, as, hopefully we're going to see in PG and Baltimore. And so it's not like this is that there's some natural barrier to keep this from happening. But there is how you organize yourself, how you set up the incentives, and how you make sure that these things, that the people get served. Without asking these, I don't mean to ask hospice providers to, lose their shirts on this deal, but is there not a better way to organize ourselves and get the incentives right so the patients get served, they get some choice, they get high quality, and the need is met?
Commissioner Sargent?
Thanks. I also will try not to be the skunk at the picnic, but I'm not usually very good at avoiding that. I had a question, and it follows some of the discussion. Looking at the MedPAC standard, that's a standard of what exists, isn't it? It's sort of the utilization across Medicare, if I understand it.
It's the percentage of Medicare beneficiaries,
right.
Medicare decedents who use hospice.
Okay, so to the extent, if one were to think that hospice is underutilized everywhere, or in general, the MedPAC standard would also sort of be below the ideal amount of hospice. In other words, I guess our use is not really trying to measure what would be the ideal amount of hospice and the need to get to that. It's sort of measuring up to this national standard. Is that a fair statement?
Yes, and again, that was a point of discussion in developing the methodology. It may be an ideal, but it's a realistic standard because that is how it is being used nationally.
Okay. And do we ever, because I'm new here, do we ever try to measure what the normative, how much hospice should there be, and try to get to that? That may be a much, much harder question, but
that became the surrogate for what should be,
okay.
And that is updated annually. So we will have a 2015 measure going forward.
Okay, thank you.
Other final comments?
Just one little one. There was a discussion of of having a little bit of at least a conversation about kind of ongoing, so that the next time this comes up, there's actually, our thinking is a little more, we're not simply responding once it's time to renew. So is there, and again, being the new guy, Is there a work group? Is there some way? Because I can tell Commissioner Thomas, certainly, that there's a number of us who would like to keep talking and thinking and going through the data and thinking about what the next step should be and what the next round should look like. Is there a process for that?
Yeah, let me suggest that Ben and I will huddle about how some of that input can kind of be had in the process, going forward. My sense at this time is that the Commission's discussion is that the staff should move ahead with the publication of the hospice need forecast, and then there would be a review schedule for CON applications in Baltimore City and Prince George's. Diane?
So I did want to comment that I appreciated the letters that were submitted and shared with commissioners, and to make sure that we keep on the radar screen not only issues around disparities but also issues around pediatric hospice, because while it sounds like a wonderful alliance of hospice providers who ensure that there's expertise around the unique needs of pediatric hospice, ensuring that it is understood and available everywhere in the state, and that it's quality services that are provided such like that. I just want to make sure that also continues to be part of the discussion.
That's good. That's a great point. And then let me just say for the minutes that Ben and I will figure out the offline how to have the proper sort of commission staff conversations around just thinking about methodologies, but that we'll make sure that formally that we keep this as an active item on the agenda. Okay. Thank you very much.
Thank you.
Okay, agenda item number 4 is around redesignation of CRISP. Under Maryland law, the Commission is charged with designating a statewide HIE, and David Sharp will present an overview of CRISP's initiative, and then we'll review the key elements in the Maryland state-designated HIE agreement with CRISP. David?
Good afternoon, Mr. Chairman, members of the Commission. Let me just get things set here, and we'll be off and running. So before we get started, I'll just encourage everyone to look at the slides as opposed on the hard copy or electronically, as opposed to what you see on the monitors. I realized this morning that the lettering on the monitors appears to be quite small. However, it is okay if you're able to see in the larger screen in the back. So this afternoon, I will provide an overview of CRISP services, and the state designation agreement. I would like to begin our discussion this afternoon by reminding commissioners of our role in HIE and health IT in general, and that is MHCC is responsible to advance a strong, flexible health IT system that can appropriately support clinical decision-making, reduce redundancy, enable payment reform, and help transform care into a model that leads to a continuously improving health system. The graphic on the right depicts where we are moving toward, which is using health IT as a tool or enabler, if you will, to support clinical decision making and lead to practice transformation and reform. So the graphic that's in front of you, this particular illustration is a good way to think of how electronic clinical information flows with, in this case, CRISP being the state-designated HIE, but there are also other HIEs in the state, operating in the cloud that moves back and forth bidirectionally clinical information in generally thought of as a standard format. In 2005, MHCC initiated the development of a guiding principle around interoperable and secure statewide data sharing utility, which today we refer to as Health Information Exchange. For many of the folks who've been around a while, you might have remembered the RIOs, and you might have remembered even the earlier concept of CHINs. So this is where we've evolved to today. In 2008, MHCC and the HSCRC funded 2 multi-stakeholder groups to develop competing approaches for statewide HIE. Then in 2009, the MHCC designated CRISP through a competitive process as the state-designated HIE. And CRISP is a 501c3 independent non-stock Maryland membership corporation. The founding members include Johns Hopkins Health System, MedStar Health, University of Maryland Medical System, Erickson Retirement Communities, and the Erickson Foundation. So I thought I'd give you all a glimpse, unfortunately it's a very small one, if you will, of the hierarchy, the organizational structure, and again, I apologize for the small font. What you see down the right column, just to get this thing started, is the board structure. It consists of 9 of its original members. The board also has 2 payer representatives, 2 representatives that are appointed by the Secretary of DHMH, 2 community representatives, and 2 small practice representatives. The board also includes a number of ex officio members. The MHCC happens to be participants on the board as ex officio. The organization is structured, the government entities towards the left, the CRISP board in the middle, and then the CRISP advisory boards, which I'll talk about shortly, all to the right of that. CRISP makes use of a lot of advisory boards to really help drive their decision making. And then, of course, the bottom block shows the staff. CRISP offers a number of services. I thought I'd touch on the leading services this afternoon. The CRISP Query Portal, it's probably one of its earliest and longest running services, allows providers to securely look up patients through the internet. Direct secure messaging enables secure point-to-point messaging among providers. This messaging consists of clinical information, generally speaking. It has the encounter notification service to providers, which lets providers know when patients have had an encounter at a Maryland hospital. It includes the encounter reporting system, which are monthly reports to hospitals on inter-hospital readmissions. And then the last of the largest services is the prescription drug monitoring program, which is where CVS dispensers electronically submit information on drugs dispensed to patients. This information is securely maintained and presented by CRISP to professionals wanting to identify whether or not patients have had certain schedule of drugs. This graphic is really hard to read, so again, I would encourage you to look at the paper. It speaks to some of the key performance metrics, and I thought I'd walk through this on the paper. The key categories of reporting by CRISP to MHCC are elements under the ambulatory practice, hospital encounters, long-term care, data consumption, use of the CRISP portal, and some beginning consumer metrics, which we'll have more of over time. Across the top, you have the 3 months, and we use those 3 months to give us a growth rate, which you'll see in the last column. And then the total, the first total that you see in terms of number, is the actual number since CRISP began operations, going down the page, and then, of course, the column is next to it, adjacent to it, is the percentage of growth, or the percent of those providers that are using the system. So I thought I'd point out on this page what might be of interest is that we have, in terms of Maryland consumers, about 5,800 that have opted out of CRISP, and the NPI has more than 15 million identities in it today. So those identities aren't strictly just Maryland residents. There are identities for cross-border services. CRISP has work in Delaware, doing work in the District of Columbia, and it also includes some work that is starting to get underway in Virginia. On the next set of graphics, I thought I'd bring your attention to some trends that might be of interest to you all. The 2 graphics report on overall on queries and ENS notifications. On the first part of the page, you see monthly queries, and typically it's on the rise. We're getting about 104,000 queries a month, which is really sizable given where we were back in 2013. So the trend line is, as we hoped, continues to climb. On the ENS notifications, you'll see about 720,000 of those, with a very similar trend line overall. On the next graphic, we're looking at query portal by users, and we're calling it out in 3 ways. Active clinicians, which is the more orange line, unique users, which is the green line, and then active single sign-on users, which is the smallest line on the bottom, but it's growing. Single sign-on today is available. It's been integrated into about 16 hospitals. The idea is to get it built into all hospitals' information systems. And the advantage is, the largest advantage is, once built in, it becomes part of a work stream or a workflow and doesn't require any of the users to go outside of the normal routine of care delivery to find out information that's available through CRIS. On this last graphic, I wanted to bring your attention to the budget or the financial trend since the last state designation agreement was put in place, which was 2013. And you'll see sizable and steady growth. In 13, CRIS was largely funded by grants that it received both from the state through the HIE Cooperative Agreement Grant and the REC, and then also includes hospital payments of about $1.5 million a year. And then in 2014, the Medicaid through the IAPD under the federal government begins to offer a 90-10 match, which makes it funding available for CRIS to do services related to health IT and the CMS EHR incentive program. In 2015, 16, and then what you see projected for fiscal year 17, that largely reflects the ICN, the Integrated Care Network, which I'll talk about in a few minutes. But these are new programs that are being developed and funded largely by the Health Services Cost Review Commission through rates. So, moving along, in this slide we're looking at collaboration with state agencies, the work that CRIS is doing for state agencies, and there's a few of them that's probably most notable. In the Behavioral Health Administration, CRIS serves as the access point for clinical providers that provide, including pharmacists, prescribers, and other licensed practitioners, to the prescription drug monitoring database. As it relates to the Department of Health, CRIS provides technology connectivity assistance for portions of its syndromic surveillance and immunization registry, as well as the reportable labs program. For the Maryland Health Benefit Exchange, CRIS manages the interface for the provider directory. For Medicaid in general, CRIS supports the CMS Meaningful Use Incentive Program, which I discussed a few moments ago. And as it pertains to work for CRIS with MHCC, several years ago we awarded CRIS funding that we received through a competitive grant by ONC for developing electronic advance directives pilot, showing to be able to demonstrate that electronic advance directives could be connected to a state-designated HIE. CRIS also serves as the entity that tags, if you will, through the MPI, Enterprise Identification Number, on carrier eligibility files for the APCD. So we talked briefly a few moments ago about some of the expansion initiatives that CRIS is beginning to embark on. CRIS is developing an ICN, or as it's referred to, an Integrated Care Network. It's an infrastructure to support care coordination, care management efforts that will lead to better patient care, improved outcomes, and lower costs. The ICN is being developed through new efforts on the existing platform under the guidance of the WAVE, or the All-Payer Hospital System Modernization Activities. And CRIS has organized this build-out, this enhancement, if you will, to its infrastructure into about 7 work streams. And they are ambulatory connectivity, enhancements to the data router, clinical portal enhancements, the notification alerting we talked about a few minutes ago, additional or expanded reporting and analytics, information related to basic care management, care coordination, if you will, and then a practice transformation, helping to move practices forward as they begin to transform. So what I've included here is a concept model that I'll walk you through, and it's probably easier understood if we think about it in thirds. If you look at it from the middle swath, which is the blue, where we see HIE infrastructure, we think of it today with the hash lines being new or need significant improvement. This is the infrastructure where CRIS is starting to make all the changes to, at least initially. So anything in the middle that you see is blue. Most of these services are offered today, the clinical query portal, the identity management, the encounter notification, but the funding, the efforts under the ICN will actually increase the capabilities of these features. When we think about new tools, we go up to the next layer where it says new tools, and we look at some of the projects that support the work streams that I noted on the prior slide. which is in-context notification and alerting. They'll embark on more of a risk stratification and predictive modeling tools. The care management software is important for a lot of the CMS initiatives that are coming out. Care or data router and clinical data normalization. This is interesting because what we have today with EHRs is everyone records some information differently, and how do you extrapolate that information into sort of a central document that everyone can make sense of as that patient moves downstream. Some enhancements to the query portal, and then the clinical document architecture, the CCDA, looking at parsing out the data. And lastly, at the bottom are mostly inputs, where we think of where the data comes from. But I would call out what's new here is the use of administrative data from electronic health networks, which take the information from the point of which it's billed from financial systems and can be used to provide basic ambulatory alerts to providers downstream, and also can be used for some analytic purposes, even though financial data coming from a billing system is not typically clean or final. The Medicare claims data, which we do not have, Chris does not have as of yet, and they're looking at how they might be able to get that data, and then enrollment data as well. So this is, while it may look a bit confusing, once you study it a few times, it's not so confusing, but it is a very lofty plan for Chris to take on over the next several years. So with that background in mind, I'd like to move into the key elements from the HIE designation agreement. And part of what we're required to do by law is to designate a state-designated HIE. And CRISP has been that HIE since the process began. So I want to review for you today what's new and what's the same, and then make a request of the Commission as it relates to the agreement. So the state-designated health information designation agreement sets forth conditions of CRISP designation as Maryland's designated HIE. The 2016 agreement is for 3 years, similar to the last agreement, and this marks the 7th year that CRISP would, if approved, the agreement is approved by the Commission, serve as the state-designated HIE. The state-designated HIE is responsible for building, maintaining a technical infrastructure that can support health information exchange securely among authorized users. The agreement includes a small number of new items, and I'd like to review some of those with you. The first item in the addition to the agreement is to develop a cybersecurity plan, and we've earmarked about 120 days for getting that plan developed and using the NIST framework as the basis or the foundation for what that cybersecurity plan should look like. The next is to establish and build out a disaster recovery and business continuity plan. And we're also following in about the same 120 days for finalizing that plan. And what this should do is identify continuity of core operations that would continue to run in a declared disaster, and what actually would constitute a disaster. We also want CRIS to report annually on initiatives aimed at minimizing false positives and reducing to near zero the false positives in the Master Patient Index, the MPI. And this is important because this is how patients are linked up. And if you have a data set, the MPI has 15 million records in it, and you have 100 David charts, calling out for provider which one's the right one is an enormous task. So while the probability is in the 99 percentile range, it's still not high enough. That those tenths actually can create havoc when it comes to identifying patients. So we want to work that through, and we felt that it was important to add that in there. And lastly, we also felt it was important to add language that the HIE keeps the Maryland priorities front and center as they begin to branch out into other states or other areas, if you will. So the agreement has 8 sections. I'll review key elements from 5 of them, being that we feel those are the key elements. The first section pertains to oversight, and I'd like to talk a little bit about the bylaws. The bylaws for CRIS have only been amended one time since the organization was established, and that was in 2012. And they were amended to expand the membership to include 2 designees from Secretary of DHMH. In addition, it includes in the bylaws a requirement that board composition cannot be modified without formal MHCC approval. As it relates to the CRISP advisory committees, the bylaws enable staff to participate in those advisory committees and on those advisory boards. It also allows the executive director to request a bond or appropriate assurances in the event of a sale, closure, or transfer. And I'll talk a little bit about those items in a few moments. And lastly, any investment in major technology, the bylaws require CRISP to get approval from the MHCC. Moving, I defer to the chair, or keep moving. Okay. So the agreement requires CRISP to submit reports. The first is an annual plan, which sets forth how CRISP plans to increase connection to its core infrastructure by payers and ambulatory providers. We have hospitals connectivity, and that was easiest to establish early on. It is a very slow churn to engage ambulatory practices, and somewhat of a slow churn in being able to engage carriers in connecting to the HIE. The plan includes elements for education and outreach and current and planned activities to secure potential revenue sources. Today, CRISP is largely funded through grants, largely funded through efforts by state, and we've been trying to help CRISP since its inception seek out other market opportunities to become self-sustaining as those grants tend to wane in outlying years. They also provide us with monthly performance reports, such as those I touched on earlier. Each year, CRISP submits an annual budget that's been approved by their board, and as in one of the previous slides, it's about $31 million for fiscal year 17. While that number remains a bit of a draft, it may change. It's not likely to change substantially. And lastly, the annual report they submit to us, which is after their fiscal year ends, assessing their performance to their annual plan. Sort of a look back to say how did we do, and what do we need to do better or differently. In regards to privacy and security, CRISP must meet all current industry standards regarding system performance, business continuity, technical resources, and system security. CRISP must comply with all federal and state laws. We have regulations today on privacy and security. The Commission has been very active in guiding staff in the development. We also make use of a staff advisory board. They provide us with suggestions. All this has led to COMAR 102518, and if you'll recall, a couple months ago, you all approved proposed changes for publication to that particular regulation. The MHCC may require CRISP to obtain national accreditation from an organization recognized by the MHCC. And those on the Commission for a while recall that we, for electronic health networks that move administrative data between payers and providers in the state, they too also have national accreditation. And national accreditation just helps establish a bar, and we point to ENAC as that entity in which they would meet that certification today. HIEs aren't mature enough yet, to be frank, to meet any sort of national security accreditation on the HIE. But as it matures, the industry matures, and more national standards begin to emerge, that might change in the years to come. The agreement specifies requirements regarding annual audits, two in particular: a financial audit, which is a review of the financial statements that end on their June 30th period. It relates to cash flow activities for that year end. And the second audit looks largely at technology. The audit pertains to privacy and security, and a review of data processed, transmitted, and stored by the HIE, and defaults back to HIPAA and high-tech as the foundation or the framework for that security audit. The agreement also includes language around changes to the CRISP organization. In the event that CRISP should elect to sell or to merge or to lease, CRISP must submit a plan that assures to the MHCC that there would be a destruction of data contained within the HIE core infrastructure, or that the secure transfer of information to an approved entity within 6 months prior. In addition, the state, each organization with an existing participation agreement with CRISP must be allowed to choose to continue with CRIS or look to an alternative source during the transition period in the event that there's a sale, merger, or lease. And finally, as it relates to closure, as soon as CRIS has information regarding its ability to continue to operate as a state-designated HIE, and not less than 6 months prior to its closure, it must provide written information with a plan to address destruction, transfer, and compliance with state and federal grants, and provide participants with notice of the closure. And lastly, CRISP also must support critical services during the selection of a new state-designated HIE where that becomes possible. So this is the last slide on the items we'll talk about in the agreement, and it stems around cooperation. And in this, we look to CRISP to make connectivity reasonably available at a moderate fee to HIEs that are recognized by the MHCC. We have about 7 HIEs in the state in total. These are largely hospital-based or community-based, and they're providing services in small pockets. And what we want eventually to be able to happen is those HIEs connect into the larger HIE, so you can take advantage of an MPI for patient identification. You can take advantage of moving clinical information, CCDAs, out to the further extremes where ambulatory practices may have relationships with community-based entities, but not with a statewide HIE. So this information eventually gets to the ambulatory practice in the field, even if they don't sign up directly with CRIS. As far as other elements of cooperation, they must participate in any health information technology-related work group of the MHCC, and CRIS has been very active over the years on all of our health IT-related initiatives. And lastly, CRIS must collaborate with staff, consumers, and stakeholders concerning the development and implementation of new use cases. So moving on to the requested commission action, staff recommends that the commission redesignate CRIS and approve the proposed agreement. And I can pause, Mr. Chairman, for questions, comments.
Excuse me while I fumble with my microphone. I have 3 questions. Actually, they're a little bit in different parts of the presentation. One of the things, you referred back to the early days in 2005 when this was all being put together, and one of the arguments that was made at that point to gain funding, basically, but it was not disingenuous, as we were still reeling from the anthrax scare of the year or 2 before. And one of the systems that they were proposing at that time, which I didn't hear, I mean, you laid out a lot of very interesting applications of how you would use this data, but was an early warning. I mean, in the anthrax, I mean, luckily somebody caught it as, 3x5 cards got faxed over to state health departments in 3 different states around the country, and somebody was smart enough to say, boy, that's an awful lot of ER visits for this funny set of symptoms. And one of the things was that these sort of systems would have kind of an early warning, that all of a sudden if you saw a pattern in the data would be fast enough coming in that you could go, we have SARS, we have, whatever. We have certain, and is that a component here and I just missed it?
So the question around, could the HIE serve as an early warning indicator?
Yeah, kind of a public health.
It is conceived of doing just that. Today, it's not baked in enough statewide that it can work effectively. But there's been discussions at DHMH about how we can take advantage of CRIS for public health reporting, public health emergencies, for outbreaks. We're just not there yet.
Okay.
Yeah.
And one, just to be more, a little not jaded, but practical, let's say, then that also, things like CDC funding, things like that might become available as well for the funders that is really their main policy goal. The other question I had to do, well, one of the other questions I had to do with this relationship between CRIS and us. And I see there's lots of interaction with the staff and whatnot, and there's an attempt in CRIS to have a very representative board of both stakeholders and different interested parties and stuff. But the commission, none of the commissioners serve on the board. Is that ever been considered?
So yes, we talked a lot about that in its early days, and what we tried to separate ourselves from as the regulator of the entity to not serve on the board.
Okay.
That's why our role today is ex officio. However, DHMH does have 2 appointees on the board.
Okay. Okay. And so that would be just kind of food for thought if there was some other way that we might want to think about doing that. The other thing is, unfortunately, when you were talking about the close down procedures, and they were very good, sort of if something happened, if they sold or whatever. Unfortunately, I've been involved in some situations where that close down is about a 24, 48-hour event. Somebody's funding doesn't come through, some CEO leaves and didn't mention the $5 billion, whatever. So I just didn't know what, if this had to be greatly accelerated. I mean, because you sort of said within 3 months, we'll let everybody know. Is there a, oh my God, the offices are empty, they're gone? Is there something for a very sure, precipitous close down of this organization that would protect the safety and privacy of this data?
So we don't, I'll call it a doomsday plan. That doesn't exist. However, I think there is some assurance in knowing that the organization is owned by lots of large health systems.
Mm-hmm.
The board meets every quarter. It has internal auditors that function from Hopkins.
Mm-hmm.
So the financials are looked at very closely. They're looked at very closely for solvency. They're looked at closely for cash on hand. There's a lot of policy people involved. There's interaction between CRISP and us that occurs monthly. In fact, there's probably not a week that goes by that we're not working with that organization daily. So there's a lot of things happening that would give us flags if there was something that gave us pause about whether or not there's a possibility that funding could be eliminated.
Okay. I guess my only recommendation then would be is if there's a way to think in terms of the way you're setting up the financials or recommending that they set up the financials, that there is some sort of a some sort of contingency fund that would cover staff and things like that for a 30-day period, something to make sure that if really the sky just fell in, that it would not be the only people working are the people who agreed to do it without pay and
Good point.
those sort of ugly outcomes that can happen.
Got it. Good point. Thank you.
So CRISP is an impressive organization, and in many ways is looked at again as a national model, which is wonderful. I was very pleased to see the recognition in the slides about the importance of collaborating with a variety of stakeholders, with consumers specifically mentioned. Looking at the board of CRISP and looking at the policy advisory boards, none of them address consumer issues, and I don't see any consumer representatives on the board. So I guess it's a statement, but I'll pose it as a question. Has there been some consideration of including consumers, and are they involved in any of the governance roles of CRISP?
So, great question. The community representatives, I should have worded that as consumer representatives on the board. So yes, they are part of the governance structure. We're very mindful of consumers, and each of the advisory boards that you see, unfortunately not clearly, but in the blue boxes to the right of the, all contain consumer advisors, consumer members, if you will. Our staff advisory group is made up of a number of consumer advisors that help develop policy around privacy and security. So I probably could have done a better job calling them out on the slides, but consumers are absolutely well represented on the work that gets done by CRISP.
I'll take your word for it. I appreciate that. It's vitally important. And then one of the things that I wondered about, given that CRISP serves an essential function of ensuring the much more efficient exchange of information, that efficiency should be available to consumers as well. Mm-hmm. Under HIPAA gives consumers the right to inspect, review, and get a copy of medical records. So I was thinking, I wonder what CRISP allows. And I see that on the CRISP website, you can get a disclosure of who has requested your information, but you can't actually get a copy of what information is contained in CRISP related to your own medical records. And there's been quite a bit of research done that shows that often medical records are incorrect. and not always, but sometimes. So my question is, has there been discussion about consumer ability to access a copy of what information is in CRISP? Because again, it's pulled all together in one place.
Right.
So I don't have to go to the pharmacist, I don't have to go to this hospital or that doctor, primary care, or that specialist, so on and so forth. How do we bring that benefit to consumers, even if it's at a really basic level of simply giving them a copy of what information is contained in CRISP around, associated with their medical care?
So this conversation has been going on since day one, but it's really underway quite a bit now in the advisory groups that are working. Because historically, when I showed you that image of the HIE in the cloud in the middle, it was really a pointer of data as it flowed, and not so much as a holder of data, although what it would hold is the MPI capability. So as data flowed through the middle to the endpoints, it would know that David Sharp, this is the David Sharp that flowed through earlier, and tag it the same way so the data could keep moving. Only recently has CRISP become more of a data at rest or a repository for certain data. And that's what's led to these discussions. So historically, CRISP could say who accessed the data, could say the endpoints, because it is the data flowed, it would stamp it and it would say Hopkins, primary care blank. It would be able to identify that and could tell people where to go to find that out. So what discussion currently are underway is how do we enhance that infrastructure? And part of this infrastructure enhancement that we're talking about, which is under the ICN work here, is really to give patients more ability to control and find out their information. It starts with granular control around the patient being able to say, who do they want to have access to that information? They may want to say, I want this doctor to have access to it, not that doctor. Whereas today, you're either all in or you're out. But ideally, we want CRISP to be able to provide more granular information to consumers. More maturity in the technology is needed, but we're kind of headed down that pathway. And by the way, in probably less than 18 months, we think we'll bring back to you all policy recommendations on consumer access to the HIE.
Can I just blow kisses in your direction? So thank you for that.
Look, don't get me in trouble.
Just very briefly, when will researchers have an opportunity to access this database?
That's an excellent question.
You've heard me come at you a couple of times at this, and I'm sure there are complications, but answer it also in going forward.
So we brought to you all 2 months ago draft regulations for secondary use, or proposed regulations for secondary use of data in an HIE, which included research and emergency access, if you will, just in part. So the comment period ends at the end of April. We will come back to you. We believe if we've done what we think we have well, we vetted these drafts for 18 months to a lot of stakeholders to try to mature the direction of the content. And if all goes well, we believe staff will be able to make recommendations on the final regs to you all in May, the May meeting. But I think to your bigger question around the value of that data for research purposes, and it feels to me like it's still green. And I say that it has potential, it's maturing well, but until CCDAs, the clinical records, you have your EHRs that are holding all kinds of content. But even the richness of that content varies because they have fields and standard fields, and some people put more data in than others. But what's called is the clinical document, the CCDA, which will be used for care coordination and will follow that patient around the provider, until that is built and mature and it becomes more, it grows in terms of its numbers. The research capability is there, but it's not rich yet because you don't have all your ambulatory practices in. You have hospital data, admissions, but you think about all the endpoints. So we're headed down that pathway where it would be quality data to mine. We'll have the capability to start doing that by process, but the richness of it still will need time to mature.
I would just say the perfect doesn't have to be the enemy of the good, and if it's no good, researchers won't use it. But right now, there's no access, so let's hope these regs do allow that access. Thank you.
That's a good point. Thank you.
Just curious, with this expiring in another 3-year period, were there other vendors looked at, or the state is just totally locked into CRISP?
So so I would answer it this way. We have a number of HIEs in the state, and we're encouraging organizations. In fact, Western Maryland Health Systems just submitted an application to become recognized as an HIE. So they would be our newest HIE once that application is approved. So it's a process. So we're seeing more community-based HIEs emerge. But to become a statewide HIE, in my view, you had to get started years ago, or you have to have a lot of capital and horsepower to build these things up, because it's not a slow churn. Your big companies like an MDON, or WebMD, or Relay Health, you couldn't move into a market and just say, okay, I want to compete for being an HIE, because of the infrastructure and the connection points that you would have to build. It would take a long time. The likelihood of some of these smaller HIEs growing and over time either merging or maybe there being more competition to CRISP is possible, but it takes a long time to build these things. I think that Mr. Chairman probably can speak to that too.
I don't disagree.
So if something happened to CRISP, then...
So we thought about that when we had the concept of inviting communities to build these HIEs, to create this fabric, if you will, of a failover effect. If we, in time, the ideal model that we'd like to see is that could occur. So if there's a failure in the hub, the spokes will be able to support that failure and keep the information flowing around it for a period of time. If you think of it in terms of the net, a whale probably get through it, but all the tuna and the small fish are flying right through it. So we really have to mature these infrastructures to where the net is very tight, and even the little minnows get caught. So it will take us a while to get there, but that is the concept.
So the concept that David outlined has been one we've thought about in terms of, could we have more than one state-designated HIE? And that would require a statutory change. Given the previous presentation, you probably can visualize some of the challenges of going from a single designated HIE to allowing multiple. Would not be without some difficulty, but it's within the range of possibility, but it requires change in law.
I'm sort of backing into it a bit, as we increasingly are using enterprise systems both in the ambulatory as well in the acute setting, is under this clinical query portal that is a current, is that increasing? Is that ability to draw from the local to the state HIE increasingly more possible, or because the enterprise is across multiple hospitals and multiple ambulatory and multiple primary, et cetera, kind of absorbing their need in a way and not putting the energy in as it would be to that connectivity to have it statewide. Does that make sense?
Yes, actually it does. So one of the interesting things that we wanted to require of the HIE was that it cooperate with the regional groups. And we say cooperate because there is the ability to cooperate and not sort of squish the market and push everyone out. But cooperation also means integrating, so that you have APIs that run between the two organizations, so the information flows back and forth. If a provider at the endpoint wants to find out information in CRISP but has signed up with just the community-based HIE, they should be able to do that. As well as take advantage of the MPI that sits in the middle. So there's the notion that the information should flow, and we don't really see there being challenges around CRISP trying to push these guys out of the market, but we put it in here to ensure that that does occur, and that there is cooperation.
Good. Thank you.
Other questions?
Thank you. I thought that was a great presentation.
Thank you.
Looking at the I was looking at the sale, merger, or lease provisions.
Okay.
I assume when we're talking about lease, it's lease of all the assets of CRISP. Is that the sort of lease we're talking about to someone
That would
else?
be correct.
And we have in the contract, as I read it, provisions on if they're sold or if they merge that talks about the destruction of the records upon closure, and it looks like an approval requirement that may or may not be limited to reviewing the destruction of the records. Are there limitations on CRISP selling itself if it builds itself as the central exchange and there isn't a statewide competitor? What would be the process by which a sale would occur, or is there a review of some sort outside of this contract?
So I would point out that just to be clear, that this isn't a contract at all. This is an agreement and that CRISP has requirements in their bylaws specifically around how those sale would occur. So I'm not sure if that tempers a little bit of your questions or not. But what
it was and I didn't really have a sort of point to the questions, which I was just asking what those limitations would be.
They're absolutely required to engage the state, the MHCC, as it relates to sale, merger, or lease. And it does require input from the commission. I think if Commissioner Pollack was here, he'd probably point out that we do not want to, how can we say no to a sale or merger? But I think what we do want to do is be involved so we can monitor and provide guidance on how the electronic health information is exchanged and protected during such activity, if that were to occur.
Any questions, the commissioners on the phone?
Yeah, Mr. Chair, this is Fran. I do have a question. Thank you. And great presentation as always, David. And I really appreciate the good discussion by the commissioners, including to echo some of the comments about what a tremendous resource our HIE is in Maryland. And I think that the explosive growth in their revenues and certainly in their activity is an evidence of all of the developing use cases that can be brought to bear to this HIE. Two things. First, I appreciate the new provisions that are contemplated for the agreement with regard to cybersecurity, because obviously that's top of mind with regard to a lot of the recent events, not just in Maryland, but nationally. And so my question is actually a very parochial one. If you'll flip, David, to the cooperation slide, which I take it sort of institutionalizes a lot of the current accepted relationships. What I didn't see there was one of the real values of CRISP that, along with staff, that I experienced as a CON reviewer, which was cooperation with CRISP to vet some of the data in making some regulatory decisions as sort of as a backstop, or to widen the scope of a CON review, as one example. And I really didn't see language in there specific to CRISP's collaboration with the commission on some of our more routine business. Maybe that's understood, but I wanted to call that out as potentially an amendment there.
So I'd yield to the executive director and Mr. Chairman, but I would say that historically we've not thought of CRISP data as being to serve for secondary purposes here. We didn't think of that, and so our regulations, I don't believe, would support the way the regulations exist today on secondary use of data, at least in the draft and the proposed regulations. They would not support us as state government, the MHCC, using it for, say, a CON review. That doesn't fit, and I turn to the leaders here for.
Yeah, I'm thinking of the data we typically use for hospital CON reviews. It largely consists of data provided to us by our sister commission, HSCRC. Maybe there's some information that that CRISP has provided, but I'm not aware of any on a routine or significant basis. But I think from the standpoint of putting that in the agreement, I'm not sure how we would necessarily do that. Our relationships with HSCRC to share a pretty rich data flow from them to us and vice versa are covered by state MOUs and data use agreements that I think are well protected under current authorities.
Okay, thank you. Yeah. I'm thinking back. I think I may be confused. It may have been HSCRC data that was really useful to bring into a CON review. So I apologize because I think that was the case, and it was not accessing directly to Chris in that case. Thank you.
Sure. Thank you. So in terms of this, is there something blocking that request? So let's take our earlier discussion. If we wanted to take a look at deaths in the state of Maryland by county, over age 35, and eliminate certain things like car accidents and gun violence and different things that really weren't appropriate for a hospice set of services. At the kind of data, one, that they could supply, and is there anything in the current agreement that would restrict our ability to ask them for that kind of a?
So I would answer it in two parts. The first question regarding the availability or the richness of the data, it's not there. Because, again, it's largely served as the pass-through of data, not so much a filter or an aggregate source or repository. In time, I think those kinds of questions, you might be able to call out and do investigations of it within the HIE. In the agreement, we'd have to look at how the secondary, it all stems from on the secondary use regulations that are proposed, how the request comes in. Is there an IRB involved? Should there be an IRB involved? How's the privacy and security of the patient information protected? So it goes back to all the fundamentals of what researchers have to do to acquire data. But it does exist, and if the richness of the data were there, then those kinds of questions could be posed.
So I think, just to add one brief statement, that I think we would subject ourselves to the secondary use requirement regulations that we've established. I don't think it would be desirable to carve out through this agreement some sort of specialized data access to Commissioner Stollenwerk's point. I think David sells himself short that the staff HIE work group was dominated, to my mind, by consumer representatives, and they would certainly be howl if they knew that the MHCC, who had convened them, had carved out a back door for us to get access. I think the expectation, like everyone else, we would present our use cases through these regulations, and I think that's probably the appropriate way to go.
All right, let's move to a vote. All in favor? Aye.
Aye.
Any opposed? All right, motion carries. David, great job, and it sounds like there's be lots of interest when the secondary use regulations come back.
Indeed, thank you.
We're up for the final report on the telehealth round 1 application. In October 2014, the Commission awarded 3 round 1 telehealth grants focusing on transition of care between hospital and nursing homes. As noted earlier, one of the awards was serving as the foundation for a larger grant for PCORI, and Angela Yvette, Chief of the HIE, will present the results of the first round telehealth project. Angela, you have a whole group.
Thank you. Just making sure everybody got into place.
Or go back to school for that.
Do we have the clicker? I'll advance the slides for everybody. Great. So good afternoon, Commissioners. We're very excited to present to you some of the findings from our round 1 telehealth grants. You might have heard some of the work of our 3 awardees during our symposium that we held in February 2015. But it's an opportunity for these folks to come back and talk about some of their experiences and some of the important lessons learned that we hope to share with the industry. So a little bit of background, Maryland law established in 2014 authorizes MHCC to award grants to certain nonprofit organizations and businesses. We have currently 3 projects in place. Our round 1 folks who will be speaking with you today. Their project was over 12 months, October 14 to 15. And just to remind you, these are small grants of about $30,000 or so from MHCC's budget, which are matched either 1-to-1 or 2-to-1, depending on which round they're in. Round 2 are our June 15 to November 2016 grants. Those grantees are demonstrating the impact of remote patient monitoring on hospital readmissions in various settings. And around 3 folks that started this past December and will continue through May of 2017 are demonstrating the impact of telehealth to improve patient experience and overall health, particularly for those chronic conditions. The aim of these telehealth grants is to really test the specific diverse use cases, to test the effectiveness of telehealth in various settings with various providers, patients, clinical protocols, and technologies, to really tease out some of the challenges and obviously successes that we hope to share with the industry. What we found is a lot of our previous round projects are also successes of those projects are being shared with the next to build on each other. These specific lessons learned, particularly in the report that was presented or provided to you today, will hope to inform better practices in the industry, potential policies to support the advancement of telehealth, as well as kind of larger telehealth projects are going on across the state. And some of this work has already been used throughout the state. So just a bit of background on our round 1. Again, it's a 12-month project which we funded, and these projects were to demonstrate the impact of telehealth, specifically audio-video consults between a acute care hospital provider and the nursing home resident and provider during certain changing conditions of that patient. We're assessing the impact on transitions to hospital admissions, as well as specifically 30-day readmissions. The grantees that we have here have been awarded, that we have here today, are Atlanta General Hospital, and they partnered with Berlin Nursing Home and Rehabilitation Center. Dimensions Healthcare System, who partnered with Sanctuary of Holy Cross and Pawtucket Health and Rehabilitation Center, and finally University of Maryland Upper Chesapeake, that partnered with the Bel Air facility of Lorien Health System. Just to summarize the key points that are in the brief around the project lessons, particularly on the technical side, although all of our grantees conducted technology readiness assessments, what they found is that there was a strong need to bolster the bandwidth and Wi-Fi strength in some of these long-term care facilities, particularly related to support that audio-video consult, particularly for those grantees that are using mobile telehealth carts that might be wheeled to a different floor or a different area of the facility. They needed to build those strengths. Staff training is always key for technology implementation and projects, but we also found, given the use case, there was a need to test the technology and make sure it's ready when it's needed, because it wasn't sort of a day-to-day, everyday use. But also continue to train staff and refresh training when they haven't used the technology for some time. And then key was engaging the consumers and staff, educating families and building their awareness of telehealth before it was needed was certainly key. A lot of our grantees either presented the telehealth technology either at before discharging from the hospital or upon admission to the nursing facility to really engage with the families. They provided flyers or videos to let them know what to expect if there would be a need for the telehealth consult. Early identification and continual ongoing support of the physician champion and nurse champion was key. really needed that sort of cheerleader that would continue to motivate staff and lead the project through was key to their success. And then liability coverage was another lesson learned. Professional liability insurance carriers' coverages aren't explicit in their policies, and all three of our grantees needed to consult with their carriers to determine what type of coverage they had related to telehealth. And then finally, integration of data. Introducing a new telehealth system also created some challenges around accessing that system along with the CRISP system, along with their EHR individually, caused a bit of challenge. And what they're looking for in the future is sort of that integration with those technologies seamlessly so that you don't have to log into more than one system. In terms of the cost savings and sustainability, the projects did report a reduction in hospital encounters that are estimated to save cost savings, and I'll let our grantees talk in detail a little bit more about that. Because Medicare has limited reimbursement on telehealth, our grantees worked within their own budgets to pay for some of the telehealth services that weren't reimbursed. And then hospitals are also anticipating that the all-payer global budget revenue model will help support the telehealth programs as they continue. All three programs, we're excited to say, are expanding their use cases to other long-term care facilities. We just recently popped into a couple of the grantees' locations to see how that's going, and we're very pleased with their results, as well as using telehealth in other areas of the hospitals and the community. So our telehealth grants have only just begun, but they've had a large impact on the industry. We've held annually our telehealth symposium, which is very well received and attended. Care First has based its $30 million telehealth grant in part on the recommendations of the MHCC Telehealth Task Force, and staff has presented on several occasions on our telehealth work at various conferences throughout the state. So I'd like to turn it over now to the Upper Chesapeake. Colin Ward will present on the project there.
Thank you. I'm pleased to present on behalf of Upper Chesapeake Health and Lorien Health, and I'll walk you through the presentation. I also want to extend my thanks for approving the telehealth grant process. We benefited greatly from it, so thank you. Just to give you a sense of the participants and the location, it is the Upper Chesapeake Medical Center, the Bel Air location of Lorien Health, as well as the Maryland Emergency Medicine Network. That's the ED provider group that practices at Upper Chesapeake Health. And then the two technology vendors, LifeBridge Health, or I'm sorry, LifeBot presents the technology, and Citrano Labs provides some supporting clinical information that's really been critical in this process. What you're seeing here is an over-the-shoulder view of Dr. Barreto in the emergency department as he looks in on a patient. Dr. Barreto, in using this tool, can benefit from ICU-level monitoring as part of the LifeBot system, so blood pressure and pulse ox and EKG. There are basic point-of-care tests that are available, including urinalysis, hematocrit, some basic information that would be helpful in making a clinical decision. The medications that are available in the exam room at Lorien are the same medications that Dr. Barreto could order if that patient were physically present in the emergency department, including IV solutions. And then obviously you can see the capability to view that patient in zoom-in cameras and conduct a conversation with that patient. So our goal for this program has really been to maintain the treatment of that patient in the most appropriate location, acknowledging that sometimes a hospitalization is not a benign event, and that to the degree we can keep them in one location that the patient can ultimately benefit. So the metrics that we looked at revolved around 30-day readmissions, acute care transfers outside of that 30-day window, and then ED transfers. We had goals that were in the 25% reduction range. For the 30-day readmissions, we reduced it by about a third. Acute care hospitalization and ED transfers, we showed a significant reduction We didn't hit the 25% goal, although I think there was some learning in the process because the last several months of the pilot, in those two categories, we bested the rates that were part of the baseline and did achieve that 25% goal. So overall, the utilization of the technology and the availability of the point-of-care testing and the ED physician access resulted in 42 avoided trips to the emergency department for patients that, without this program, would definitely have come to the hospital. So how that impacts cost is that in terms of cost savings, not charges, but cost savings, every ED visit that's avoided, there's about $128 in variable costs that we can save at the hospital level, and about $450 for every inpatient or observation patient day that is avoided. And those dollars then can be set aside, and they actually were used to help fund our expansion of the program into 2 additional Lorien facilities. What the payer actually can experience in terms of savings, so Medicare in this example, is the cost of that acute care or that ambulance trip from Lorien over to Bel Air. So depends on your community in the state, but anywhere from $650 to $750 or $800 is what the local AMBO crew might be charging. It happens that Lorien Bel Air shares a boundary with one of the Bel Air locations for their ambulance crew, so it's very easy to get them to come over and take the patient. So this has been a real coup in terms of managing patients in the skilled nursing location. So as I mentioned, we're expanding, we're reinvesting the dollars that were saved into Riverside and Haverty Grace locations for Lorien Health. We have split the capital cost of that because there's mutual benefit for both organizations as well as patients and their families. And we have agreed, as was mentioned in Angela's remarks, about a payment process that would allow providers in the emergency department to treat that patient as though they're physically present. There is a sort of a nuance there. The coding would never be the same because the physician could not do a physical examination on that patient. So you'll never quite match it up, but we have come to an agreement that will help prioritize that patient so that we're not leaving that patient sitting in an exam room at the skilled nursing facility. So we have a quick video. It's about 3 minutes, and this I think will give you a feel for how the process works and the benefits that it's provided. This is some of our finest work. So, okay.
Includes some setbacks. A new partnership with Lorien Health. Sometimes the road to recovery includes some setbacks. A new partnership with Lorien Health, University of Maryland, Upper Chesapeake Health, and LifeBot uses telehealth technology to help patients make a speedy recovery without an expensive trip to the hospital. As Lorien staff recognize changes in the patient's condition, they escort the patient here to a new exam room that features patient monitoring and video capabilities. The nurse connects the patient to LifeBot and enters baseline clinical data.
Conditions such as simple pneumonias, mild congestive heart failure, urinary tract infections, changing conditions as far as mental status goes, low blood sugar or hypoglycemia, or high blood sugar, hyperglycemia, could be conditions we could successfully treat there.
The emergency physician expertise is just a video call away here at Upper Chesapeake Health. Providers manning the LifeBot system complete the connection and work closely with the Lorien team to assess the patient. Clinicians review critical patient data, such as EKGs and pulse oximetry, as well as lab and imaging information.
Lorien has been able to implement ISAT, so we have real-time laboratory testing available to us. We have radiology turnaround times within 4 hours, and we also have a medication drug box that is essentially matched with what we have in the emergency department with regards to antibiotics, IV fluids, and some basic resuscitative medications.
The emergency department department physician can select one of 3 cameras mounted in the Lorien exam room, allowing for visual inspection of the patient.
When I started initiating my first call, I was able to do almost a mini neurologic examination to feel better that the patient wasn't suffering from any kind of neurologic deficit or focal neurologic deficit that would make me think of a stroke. Instead, I was able to assess them, see that it returned to baseline because of the video capability.
Once all the necessary information has been processed, a clinical decision is rendered. A new care plan may be started at Lorien, or the patient can be transferred to Upper Chesapeake for further evaluation.
These patients are normally elderly. They may be frail, multiple medications. Being removed from their normal environment can cause them to undergo sundowning or worsen dementia. They can be at risk for falls, other infections. There's risks towards being in the hospital. So there's a lot of good that can come from caring for the patient, maintaining high quality care, and keeping them in their normal surroundings at the nursing home.
Our patients at Lorien Bel Air have been very pleased with the telehealth encounters. They've been able to talk with a physician at the hospital, and it gives them confidence in the treatment.
So obviously that was not a real patient there, the youngest skilled nursing patient, but you get a sense of how the program works there.
Would like to ask just a quick question. In one of your slides, it referenced patient satisfaction and provider satisfaction. Can you speak to that? You jumped right over it, and I just would like to know what you learned. Thank you.
We, after each use of the room, there's a survey for the provider and a survey for the patient or the patient's family, and so we just try and track, did they understand what the process was? Did they get the kind of information? Were they informed about the treatment options, that kind of thing? And what we found is that for the most part, everyone likes the system. They like the idea of sort of getting a second opinion from the hospital doc, whether or not there's anything to that, but they believe and trust the hospital doc sometimes that they might not if they're at the skilled facility for a short period of time. So generally speaking, the feedback has been pretty positive. And we've even had cases where there was a patient that was borderline on whether or not they should have come over, and the patient's family called and said, listen, we're all coming in from out of town, keep them where they are, because I don't want to lose him in a transfer situation. I'd rather them, everybody get there. So the feedback has been pretty positive overall.
One quick one on your cost estimates here. The 128 for each ED visit avoided. You must have very low cost ED visits. I mean, that just seems very. Or is that where you're amortizing out the cost of the telemedicine?
So that's the variable cost associated with portions of lab tests, portions of imaging studies, portions of nursing patient hours, patient care hours that can be reduced as the volume increases or decreases or the census changes.
Got it. Thank you. Yeah.
So up next, we have Charles Gazar, who will be presenting on behalf of Atlantic General Hospital, in addition to his colleague, Jennifer Lane.
Hi, good afternoon. Thank you for inviting us here this afternoon. So Atlantic General Hospital, many of you may know, is a 62-bed acute care hospital located in Worcester County, Maryland. We decided to partner with Berlin Nursing and Rehabilitation Center, which is a 180-bed skilled facility located adjacent to our hospital. We selected this facility not only for its location, but it was also a primary source of transfers and readmissions to our facility, and a great opportunity for us. One of the things I would like to share is that providing healthcare services in a rural community such as ours brings about many unique challenges that are far different than metropolitan areas here in Baltimore. We have a lot of unique challenges, the primary being simple access to healthcare services. This program and telehealth itself is a great solution to those issues with access. It provides us the ability to provide immediate access, assessments, and interventions for patients who are located in remote areas, whether it's at nursing home, it could be in an area of Snow Hill, in a school system. It has great opportunities and has been a great program for us. Okay. So the telehealth deployment of the telehealth program actually mirrored our strategic vision in that we wanted to make sure that we were able to provide the right care to the right patient in the most appropriate location. Again, any one of those domains that I just previously mentioned, that we can provide those services. You can go to the next one, and I'll let Jennifer go ahead and speak of some of this information here.
With the initial implementation of telehealth, we had to, as Chuck mentioned, we had to identify our partners. We had to have that administrative commitment, not only from AGH, but we from Berlin. Berlin is not only Mid-Atlantic company, it also partners with 5-Star Physicians. So we had 2 separate entities that we had to engage and have that commitment. Physician Champions actually was a little bit of a barrier initially of who would accept responsibility and take ownership for the telehealth initiative. And our hospitalist team actually stepped up to that challenge and with open arms, which was a wonderful surprise. We looked at 12 months prior to collect data to make sure that we were addressing the appropriate gap, appropriate level of care, and that focused in on skilled patients that were AGH only. We had the record, and the hospitalists felt comfortable in addressing those patients specifically. The infrastructure was a barrier. Berlin met that head-on and actually has initially did the upgrade, which took approximately 2 months, and have just committed to upgrading and completed the long-term care facility, as I'll mention later. So they have committed to that, and that has been completed. The collaboration with all stakeholders was bidirectional. When you'll see that later, I'll speak to the policies back and forth. The clearly defined goals, protocols, and guidelines had to be specific, clear, and everyone had to agree to them. So when we look at the reduction of admissions between the two, we focused in on, again, skilled patients directly from AGH within that 30-day window. And part of that was contingent on our hospitalist team. The reduction with the transfers, we noticed on the 30-day, 12-month data collection, was that was the highest percentage of patients that we are seeing come into our ER, and that we could have a significant impact. So we focused in on the 4 top chronic diseases, COPD, CHF, diabetes, and hypertension. So we started implementing algorithms, interact tools prior to the technology arriving and launching. With that, we saw an immediate decrease in our numbers just through process change alone. The one thing that I do want to mention, as we looked at how we were bringing our patients over, if we saw that we could have an intervention, but even with that intervention, the patient did not improve, we have the ability to bring them to our hospital, but bypass the ER. Let's bring them directly to the floor, because we had all of the information, statistics that we needed, that the hospitalist felt comfortable bringing them to that environment. So that was just to say, we had the patient, we were very close in proximity to kind of break the barriers that you have to have distance with telemedicine or telehealth. We were very close to our facility, and you don't always have to utilize ED. You're taking them out of the picture. Kind of cover the community partnerships. Information technology was very important and key in identifying our current infrastructure, and that it directly impacted how we selected the technology, and that we needed something. We don't have a very large, robust IT department that has field engineers that can go out and readily correct this equipment. So we needed to identify vendors that had cloud-based technology that could be hosted off-site. That was very important. Legal and credentialing. Go ahead. Sorry.
sorry to interrupt.
That's okay.
Just thought it was a good place there where you're talking about your approaches. Yeah, I see your challenges with your, well, basically your strategies and your challenges. And the last video kind of showed, you know, a very competent, obviously staged resident.
Mm-hmm.
How did it? And I run a nursing facility, so I'm the unique guy here. But how did it work with your residents who were not cognitive? Did it take more participation with your nursing staff?
Well, typically, if they were,
or could they even participate in the telehealth?
we had to have permission from the family.
Family, yeah.
That had to be a conversation prior to.
And those consents are obtained in the hospital setting prior to transition over to the nursing home. We actually now, in our patient rooms, we have a computer system that provides them with a video and education regarding the service so they can see that prior to signing the consent.
I mean, it seemed to be that would be at least half, probably more than half your population would fall in that category. I mean, if it's in relation to my facility, you know, very, very, and the minority of your residents are competent.
So the interesting part about that is, I think, being that the hospitalists have seen them within 30 days, there is a little bit of history. They have a predisposition or, you know, an idea of what the patient looks like and how they present. That is a tough one. I think that goes along with nursing judgment, physician judgment, and the you know, how comfortable the hospitalist is.
Thank you.
So, legal credentialing and malpractice, that actually was an unanticipated barrier. We go and facilitate through ICN and D. They were not aware of telehealth in general. They came on site to do a risk assessment, which actually lended a different viewpoint, and it was a lot of education for us. With that, we have moved forward with that. They have written the language in for liability. We had no issues being covered after the risk assessment. And moving on, it was important for us as we launch other specialty lines that credentialing takes, if it's an already hired physician, it's a 90-day process regardless. New hire physician, it'll be 120 days. So there is a time constraint on that we need to take into consideration. I did talk about bidirectional policies. That includes the integration of EHRs and how we communicate with documentation. And that was looking at, again, Mid-Atlantic, and then you have to look at five-star physician, which five-star physician record was not readily available, and we currently are utilizing a fax process with them. Interact pathways are just algorithms that we have implemented that the nurses can start prior to any interaction with or suggestion that we would have a telehealth encounter. And that's all dependent on five-star physicians, has to be ordered through them. The staff education with the implementation started about 3 weeks prior to the technology delivery, and it was heavy one-on-one clinician education, reinforcement, and what we saw was, even with the pathways, and we had a low number of telehealth encounters, that you would actually have atrophy of the process, and you would have to go back and do re-education with the physicians. On the Berlin side, this actually has been implemented into their hiring practices so that any new hires will be trained on the telemedicine initiative. If you take a look at, and it does reflect, the baseline is 17%, so that's 12 months of data collection. Our goal was set to 13%, and we far superseded that expectation. So
for the admitted patients?
Yes, for the admitted patients, and again, partly that was due to process change. Total transfers, we didn't quite hit our goal with this, and the reason for this is we looked at the total daily census, and that includes long-term care, vented, and skilled patients. So when you looked at the breakdown, a lot of that has the long-term care patients as well. So we're looking at that as our second phase of expanding into those services.
That population was excluded from the initial deployment of telehealth, the persons in long-term care or ventilator setting.
Again, we met our goal for the total monthly patient admissions for AGH to Berlin. We really focused in on sticking to the algorithms and how we could identify these patients prior to them coming over and having that consultation. So we took that from 63% to 15%. And I believe at that point, with this statistic, we only had 3 telehealth interventions. So again, for us, this was a process change. Telehealth proved to be a very good, I don't know the word I want to say, I'm sorry, lost the word. It seemed to be an adjunct to care. And we're finding other use cases for the telehealth in this setting, which is a benefit.
If I may share that as a result of this, primarily as a result of implementing telehealth services, not only did we succeed in reducing our readmissions and improving our patient outcomes, but AGH, Atlantic General Hospital, really has raised the most improved, number 3 in the state of Maryland for our readmission prevention through this effort. We also received the top 10 Minogue Award for the Maryland Patient Safety Center for our improved patient outcomes through telehealth. Some other programs too, but this is very key in that endeavor.
So as you can see, the cost reduction, it is an estimated result in that we are saving about $150,000 per month, which is a little close to $2 million a year. So it is a significant reduction, and we are doing the job. This grant initiative funded a significant result, and we're very proud to be part of that.
And to expand. Mm-hmm. And that's the last slide here, it's sustainability through the reimbursement methodologies and hopefully seeing more coverage for telehealth and remote services by the commercial as well as federal payers, helping us to expand those services, sustain them, and through additional grant funding to carry this forward into many different venues. Any questions?
Yeah, let's start here and go around.
Just a quick question about just a little further explanation. I'm fascinated by the process changes having such an impact beyond the actual telemedicine services. Not being someone who runs a nursing home, can you give me an example? I mean, the process change, did it happen at the hospital, or it seems like that it would happen within the nursing home? So if you could give an example or two of what changed that made a difference that didn't involve telehealth, but that is a result of it.
You want to take this one?
Sure. It truly was the algorithms. I think giving the nurses the option and the ability to implement care. It seemed that 5-star, at that point in time, there was a lot of transition occurring. They were having delayed calls back. We targeted weekend times, night times that they had maybe a gap in coverage or a delayed response. This gave the nurses the ability to initiate care. They changed their lab procedures, their draw procedures, and on a previous grant, it allowed any stat orders, the labs to come directly to the Atlantic General to be run. So you would have results pretty quickly. And it also implemented a change with their radiology so that we could have, a flat plate of the chest performed or, whatever x-rays that needed to be done in the middle of the night. So obviously this was not for acute care. This was, I'm seeing a change in my patient. I'm going to utilize my nursing judgment, which also was a wonderful thing for nursing. And they were able to, and then take all that data to the physician and say, this is what I have. So.
Thanks, Mr. Chairman. First of all, thank you do you want to go ahead?
Just very quickly, I want to make sure I heard this right, because the return on investment seems almost too good to be true. If it was
30,000 and a match 60,000. I mean, that's quite significant. But what I'm really hearing is that while it was a tool, you change processes.
Exactly right.
You put nurses in charge.
Well, nursing to work and at their fullest scope possible.
Exactly. To the
Whatever opened up the range of using their full range of capabilities, you made that happen. This tool stimulated that happening.
Absolutely.
And we had partners that were willing to help facilitate that
Okay.
and expand that.
And I would just say that in telling the story, don't lose that. It is not the tool. It is actually the human and the different way of thinking about how you did your practice. So I think that's quite significant, and I hope that the story is told very broadly.
Well, thank you. Thank you very much.
I would just like to commend everyone on this particular project. I'm amazed at how effective you've been in both these sites so far, and the overall ability of our staff to help facilitate this. I'm just delighted. And as a nurse, I think it's wonderful that nurses were empowered to use the full complement of their abilities and that they had the tools available to work collegially with the physician, even though they were removed physically from where the physician was. And I just think it's an incredibly successful program, thus far anyway, and I want to thank you all.
So I'm really excited about your results. Thanks so much for your presentation so far. Can't wait to hear the rest. But one thing that came to my mind as you were all talking, how many of you had issues with liability coverage, malpractice coverage issues? And was this something that is widespread enough that we should be thinking on the policy front of, as we continue to mature this sort of work, to go back and think about how we make that easier?
You're absolutely correct. I know we encountered, as Jennifer was explaining, that they did not even have coverage for this, and we had to have the on-site survey. I'm not quite sure about Upper Chesapeake or Dimension.
Yeah, we worked with Memons carrier on that, and they got approval to do it through the pilot phase. And as long as the expansion doesn't get too big, outgrow their ability, they haven't had to make any changes in their current policy.
Yes, it was a sticking problem for us as well, in part because no one knew where it stood with this sort of thing. But once we were assured the insurance carriers were on board, then the physicians were on board without any problem. But every time you go into other projects with other uses, that is one of the first things that the physicians ask about: will my malpractice insurance coverage?
So we need to just keep monitoring that over the course of time to make sure, if it is an issue across all of our phases, that we think about what policy changes are needed.
Absolutely, and we've sort of at kickoff for our round 2 and our round 3 educate the project participants about the need to contact their professional liability carrier, and we're currently working on educational information to provide on our website to stakeholders. It's in our report, so we continue to have conversations as well with some of the professional liability carriers around what coverage they do provide.
Yeah, I think Angela just said what I was going to note, is that it's important to point out that it is new for a lot of the liability covers, and we've begun to have those conversations with them.
So we'd like to turn it over to, one more, sorry.
Sorry. Just wanted to note there when we talk about the hospital savings, and I'll throw in there that I'm talking to a good doctor here, in nursing facilities, and the nurses are always in charge. So you laugh, but you know I'm right. The best doctors know that to listen to their good nurses, just like the best administrators know that they don't have a good DON and they're dead. But one thing that's I know you guys didn't know, because there's really no way to gauge it yet, and everybody's familiar with the fact that hospitals are being dinged for readmissions, et cetera. So they're in the large savings, but estimated if it comes in time in 2018 on our end, the long-term care end, we'll start to get dinged for what's deemed unnecessary readmissions to hospitals. So this process would only grow larger savings.
That's a point well taken. Actually, the facility we worked with, they have a coordinator, regional, responsible for putting in place strategies to reduce at the long-term care facility those readmissions. So they were equally vested in this effort, as you said, for their benefit as well as ours, knowing where the future for them and their reimbursement and bundling comes in.
Other questions? If not, Dr. Cooper.
Good afternoon. Thank you for the opportunity to share our information. Next slide, please. Dimensions is a not-for-profit 200 large facility in Prince George's County, servicing approximately 200 patients a year. And our other partner, we partnered with the University of Maryland, as Upper Chesapeake did as well, their emergency physician group. Next slide. Our participating partners were primarily Sanctuary at Holy Cross, as well as Patuxent, and then as we progressed in the project, other facilities did join us. Next slide. Our IT partner was ZaneNet, a certified 8A company that is accredited by the Maryland Healthcare Commission. Next slide. So our project involved looking at two things. We wanted to track a patient status during a 30-day post-discharge visit. We wanted also to look at what impact could emergency visit and consultation have on the readmission process. And as well as we wanted to also look at the patient experience. Next slide. So the purpose was designed to reduce the long-term, the 30-day hospital readmission by improving that care transition process, but also by reducing the unnecessary visits to the emergency department, again, by doing a consultation in those patients that we deemed eligible. Next slide. So the implementation process involved training with both Sanctuary and Patuxent. As I said earlier, there were other facilities that came on board after we had started. We did this by first sharing patient data at both Patuxent and Sanctuary, getting some baseline data of what their readmission data was, as well as how many patients they were seeing from our facility on a regular basis. Next slide. The workflow integration involved organization of committees that were involved both individuals at our facility as well as the comprehensive care facility. Now this was a new process for us in terms of communicating with the comprehensive care facility in Maine, which we had not done in the past. So right off the bat, being able to communicate with them more so than we had done in the past showed some benefit. ZaneNet did all the training for both the hospital staff as well as for the comprehensive care facility staff. They were very good at making sure that all the staff were on board beforehand. And as in the other studies, before the patient left the facility, a consent was obtained by our case management staff, informing them about what the project involved and what their expectations were. Next slide. The expected outcomes, again, were a reduction in the hospital admission, reduction of overall hospital admissions, reduction in 30-day readmission, a reduction in the emergency department transfer rates, and overall improvement in the patient experience. The iPad that we used was your usual iPad, the same that my kids use every day. And it was very user friendly and worked out very well with even the most novice. Next slide. It was attached to a Jayco cart, which made it easy for us to transfer it around the facility, both at our hospital as well as at the nursing home facility. It also it also made it something that was made it secure for us as well. Next slide. The software was put together by ZaneNet. It was a house call. They called it house call. It was a cloud-based software that allowed us to both see our patient that we were communicating with, as well as the patient to see us as well. As we've since modified it to allow us to actually add data to it as well. But at the time we did this project initially, it was we could set up a database showing that there was going to be a consultation done in the system, and then it allowed us very easily to see each other very well. Next slide. We also, Chris was also a partner in this process. It allowed both the hospitals as well as providers to receive real-time alerts on when their patients were being readmitted to the facility. Next slide. So here's our data, and I apologize for the size. The first line there is really the baseline data that was achieved by both Patuxent and Sanctuary during the ramp-up periods. The second line there is the 30-day readmission visit, and you can see that we actually achieved a significant decreases in both readmission visits at both Patuxent and Sanctuary. The last category there at the bottom looks at just readmissions to the ED, and you can see that Patuxent did have some significant reduction. We did not have significant reduction at Sanctuary, and it's in part because our numbers were very small. Next slide. So lessons learned, I think, were significant. One, we learned that it's important that there be a lot of initial training, that the training be done well ahead of time, that all of the partners in the process are comfortable with it. A champion is very important. It's new often to the facility, so having someone who is going to come back off, be able to champion it, make folks feel comfortable is critical. Engaging the physician staff is absolutely critical. They are the folks who are going to be obviously these patients you're going to be caring for. Having them be a champion as well is important. Education of the patients and staff. Key parts of the process, and then finding the support and staffing as you go through the process as it progresses is important as well. Next slide. Sustainability. These are some of the things that have already been talked about. Being able to invest in the hardware that is necessary to keep up with the changing environments is incredibly important. Being able to have data that shows there is return on investment, the kind of data you've seen here today, is incredibly important in terms of being able to now and get facilities like ours to invest more so we can grow our platform. And being able to have staff be trained on a continuous basis, so it's not something that's only occurring in projects like ours. Again, is important as well. And again, finally, being able to the internal resources, the IT support to grow it, so that you can find other sources for it are incredibly important. I would only end by saying that one of the things that you would think would be a challenge that was alluded to earlier were the patient's interaction, and actually the patients were really actually quite comfortable with it. We would once we when you did the consultations, we did it. We would talk to the staff, the nursing staff first of all, because what we wanted to know was the transfer process that we did. Did you have all the information you needed? Was the discharge summary adequate? Was the patient as billed? And then we would go and we would get some idea of how well our process was from the time we initiated the consultation of getting a patient to the facility to the time the patient actually arrived there. We then asked the patient, was this facility that you got now, was it as billed? Was the information we gave you before you made the decision to go there, was it adequate? And so for the first time, the patients are getting asked questions they haven't been asking for. We're asking about their patient experience. And so it was a very positive response to that, in part because it was something that they weren't being asked before. And most of them actually all of them were much more comfortable in front of the monitor than I was. They actually enjoyed the attention. Nurses, no offense meant, but their shows can be quite boring sometimes. And we gave them this was something different for them to do. They looked forward to. We did the consultations every 2 weeks during that 30-day stay as permitted. And as I said earlier, they were quite comfortable with the process. Thank you.
Thank you very much. I'd like to just sort of tee up a question to you, Dr. Cooper, and then actually to all participants. I don't want to necessarily go down the deep hole of how much policy needs to be changed around reimbursement. I'm just curious if from the institution's perspective, could you continue this effort without grant or changes in policy because the internal economics are compelling enough? How do you guys look at that question right now?
So I've actually already taken a proposal to my CFO and requested that, and to our IT staff, requesting that we look at what is needed to really create a telemedicine platform. And I showed our data and some of the data by my partners here to them as well. But clearly, it's an expense outside of where we are right now. But what I'm saying them, and what was also true is that once you have it there, you will find always all kinds of ways to use it that will enhance patient care. For example, if I have it's like a trauma patient that I see comes in with some complex kind of hand injury, my hand surgeon doesn't stay in the hospital. He or she's at home, and I may send them pictures is one example. But being able to actually bring my iPad to the bedside and being able to perform a motor sensory exam on them gives them much more information than a still shot. That may be true if my CT surgeon is home, etc. So there are all kinds of uses that I am making an argument for once I have it there. The question, what I haven't got is how to make sure they get reimbursed for all those consultations outside. But the uses are there. If I can then build and make the argument that reimbursement can be as a platform, make sure it gets reimbursed all the time, then I'm good. But that's where I am at with
that. So I think for us, the thing that was most striking, I think we alluded to it a little bit prior, was that this has really helped the clinicians in the nursing home sort of rise to the level of their scope. So in many cases, the use of the exam room doesn't include a connection back to the emergency department at all. So for us, our ROI is what's the capital outlay to enable the skilled nursing facility to function at their highest level. And the amount that we have to pay to the emergency department to cover those calls that they can't address themselves has proven to be a smaller amount at the outset. So for us, the ROI pays for itself pretty quickly off the cost savings.
I think the only thing that I would add on top of that, would be that certainly with global budget revenue, we're making gains in taking care of the patient, keeping them out. That's an obvious. We will need, through additional grant funding, we're able to kind of sustain what we have going. As it, he had mentioned, it's here. I don't need to do too much with it, but in 5 years from now, I need to take an accountability for replacing equipment, retaining staff, so on and so forth. It's the adjunct services that we are launching that needs the startup. For us, we did not have anything implemented, so that came out of our capital. I think needing reimbursement for these services is going to be crucial down the line for us. I don't want to speak for Mr. Franklin by any stretch, but I do feel that reimbursement is going to be a source for us.
Reimbursement and regulations. It's making sure that they're all consistent, whether, again, it's a federally funded program or a commercial program. In fact, that's what I'm working on presently, are these agreements, making sure that our agreements contain the reimbursement stipulations, and that COMAR and the other regulatory bodies embrace this.
Dr. Cooper, with regard to the hand surgeon you mentioned, used as an example, is this physician an employee of the hospital or is he a private practitioner?
In our situation currently, if I look at just our hand surgeons, they are contracted physicians who are outside the hospital. So he's a private practitioner, in other words, and so he could bill for that.
Okay, so he would bill directly. I'm wondering, and I don't know if our chair or our executive director would want to comment on this, or anyone at the table, what creative changes in the law might we want to see to enable the reimbursements to go through in the most helpful manner, especially in light of the global budgets? I'm just thinking, the hospitals, if they're contained by global budgets, mightn't they want to participate in some of these cost savings? Any thoughts on that?
Right, can I take that? So at the national level, the CPT ROC is about to introduce some CPT codes that will allow for telehealth. Whether they will cover surgical billing, I don't know yet, but it's a very strong interest at the national level in terms of Medicare patients.
So just 4 years ago, we changed Maryland law to enable private payer for insured products to bill, to accept telehealth services. The uptake has been very modest. I think if you Medicare has a much more limited program, and it's until recently was limited to HIPSA health provider shortage areas and other remote rural areas, and uptake was very small. So I think the point that all of these people have made is that you have to have some infrastructure investment before you can really enable some of this to occur. That's necessary. 2, there are liability issues that are going to need to be aligned, and 3, that there's really workflow changes that have to take place on the part of providers, even when this is available. And I think telemental health is probably the most obvious area that providers don't feel all that comfortable with this until they get accustomed to it and go through some orientation and figure out how this changes my practice going forward. So I think it's not just reimbursement, it's investment, it's changes in liability, and it's workflow.
In thinking about reimbursement, to a certain degree, it depends on kind of the business case you're making. For this one, in avoiding hospital readmissions, as an old Fed, the hospital who's going to have to pick up the cost of this readmission, an unreimbursed readmission, that's where you go and ask them for money before you come to the feds for it. Now, what you've done, though, is you've made kind of a base case that then, as you say, you can pivot and do other things with. And so that's probably an area where you're more likely to get a more receptive. Well, as Ben pointed out, part of what was going on with this over the last decade or so is people like the Indian Health Service found this was great. Even in the psych, they found people like getting dressed up to have their psych session, and putting on suits and ties out on the reservation in the middle of Alaska someplace. And so they had a lot. So then to use that in terms of underserved rural areas beyond, an American Indian population, that's the policy development that I think, at least what I saw when I was, that sort of building block. It's going to work. It's not just somebody, sending out a videotape and charging the feds $200 for having mailed a tape to somebody or a disc. So you have that kind of, and unfortunately there were some shady kind of uses of telehealth in the very early days. So coming over that, finding the case, but at this point, I think you've demonstrated some wonderful results. I think as you move off into these other sorts of use of consults, being able to have whatever, different kinds of providers brought in a much more reasonable way. The most of the good work I've seen in that comes out of the private sector. It comes out more out of the Blues and some of the other health plans who really want to have that 24-hour call before you go to the ER, and they need physicians to man that and look at the pictures and be able to do something smart. So I think you've done great work. Don't get too excited about reimbursement yet. I think it's going to be a little more uphill.
So I'd just like to thank all of the participants. I mean, this is beyond, I think, what we hoped for a year and a half ago when we first approved the first round of grants. And so really appreciate your hard work and the impact it's had on patients. Yes.
This is more a comment to the Commission overall. It would be really interesting to find out from carriers why there might be hesitation or slow uptake in reimbursement for telehealth.
Okay. We'll check on that. So, Aaron, now moving to the legislative actions affecting the Commission. I wanted to thank all the commissioners for participating on the weekly legislative calls the last month, and our work enabled the staff to take a lot of stronger positions on several bills. And I'm pleased the General Assembly passed SB 707, which was the single most important piece of legislation for the Commission. And Erin is going to review legislation that affects the Commission and outline work that awaits us over the next several months. And before she begins, and I think you're going on vacation after this, right? Yeah, I'd want to recognize Erin for her work with the committee chairs and the staff throughout the session.
There we go. Thank you very much. It was a trying session, but it was actually kind of fun, although maybe I need to redefine fun. So I just wanted to say that session ended on Monday, March 11th. Thank you all for all of your hard work, and Ben and all of the staff here at the Commission that were involved in helping us move forward and push our positions as far as we could. So first, I will talk about requirements that are of the Commission due to legislation that has passed and was enacted. This includes some requirements under the Advanced Directives Bill, House Bill 1385, and under the Freestanding Medical Facilities Bill, SB 707. SB 707 actually passed on sine die at about 6 o'clock, the weekend before sine die. At one point, the Senate refused to pass any more House bills out of the Rules Committee until the House did some work on the House version of the Freestanding Medical Facilities Bill. So this piece of legislation became the roadblock in moving session forward. Some other requirements and responsibilities that came out of legislation that did not pass, but there will be some work on these issues, including issues around self-referral and clinically integrated organization. So first, I'll quickly go through House Bill 1385, Public Health, Electronic Advanced Directives, Witness Requirements, Information Sheets, and Repository. Our involvement in Advanced Directive dates back to the previous administration, I believe 2013. We were asked to establish an Advanced Directive system that can interface with CRISP, and we were given about $100,000 in the fiscal 2014 budget or 2015 budget to work through that. We contracted with AdVault, and that contract ended last year. The new legislation requires MHCC to approve electronic advanced directive services that can be interoperable with CRISP. The idea behind this legislation is to open up the state to more for multiple vendors and try to increase the use of advanced directives. Okay. The next piece of legislation we've talked about over and over and over again, SB 707, freestanding medical facilities, certificate of needs, rates, and definition. It requires MHCC to establish regulations for freestanding medical facilities that come from conversions of underutilized hospitals. Regulations must address the public notification process. They will be incorporated into the current draft of the freestanding medical facilities chapter of the State Health Plan. We see this as 2 tracks. Track 1 would be the establishment of an FMF through a certificate of need process. So this track would add capacity into the system. Track 2 would be a conversion of an existing general hospital to an FMF via a conversion. So the idea here would be this would be an exemption process. It should be a little bit more streamlined than a CON, as it would be taking capacity out of the system. Staff expects significant stakeholder interest in developing the exemption process, and Paul and his group will be working on this throughout the summer. The legislation also establishes a rural health work group. MHCC is to staff this work group and also designate a chair. Members include 6 members of the General Assembly, the Secretary of DHMH, CEOs of several rural hospitals, and other providers, consumers, local governments, business, labor, and stakeholders. The purpose is to examine the challenges for delivering healthcare in the 5 mid-shore counties, review policy options developed under the study, which is required by the legislation, and I will talk about that in a minute, and make recommendations to the General Assembly on approaches for effectively meeting the needs of healthcare in the mid-shore and among rural populations generally. SB 707, like I said, also requires MHCC to convene to produce a rural health study. We will be contracting with a group that has expertise in rural health. We'll be writing that RFP in the next couple of months and putting it out for bid. The study needs to examine the challenges in healthcare delivery in the 5-county mid-shore region, examine economic impacts of hospital closure and conversion, identify opportunities created by telehealth, the Maryland all-payer model, and other new delivery system models to improving health in rural communities, and develop policy options for addressing the healthcare needs and delivery system in the 5-county region and among rural areas generally. Just quickly, I want to talk a little bit about what staff will be working on that for legislation that did not pass. None of the bills that we talked about relating to the Maryland Patient Referral Law passed. The bill that was being championed by the Hospital Association, we've been calling it the Collaborations Bill, failed about a week and a half before session ended, and MHA was asked to continue to convene the stakeholders to talk about work that can be done over the summer to create a piece of legislation that could be passed next session. The oncology, the bill that was being championed by the oncologists, which would be a pilot program for medical oncology, failed 3 days before session ended, and legislative leaders will gather the groups to discuss the oncology pilot project. Lastly, there was a piece of legislation introduced late in session that would have altered the clinically integrated organization statute. This bill did not make it out of committee, but the MIA, who never had regulations for CIOs after legislation was passed in 2010, will now be working on developing regulations, and MHCC will likely have a role in those. That concludes my presentation. I'd be happy to answer any questions.
questions for Aaron?
Have a good vacation.
I think so.
Thank you.
Okay, thanks. Excellent job. Ben?
Yeah, I just wanted to observe again that we started out the effort to develop an exemption process for hospital conversions, but as we moved through the legislature, the process of changing our anything related to CON was again brought down hard on us as different interest groups thought they saw opportunities to carve themselves in and carve themselves out in a variety of ways. We, with the various supporters, managed to resist the most, I guess I would say, obnoxious elements. But I think it is indicative of how difficult changes to the CON statute going forward are going to be. And as you know, it's been a priority of mine to modernize, but trying to change one narrow section of the law as it relates to greater flexibility at times during that 90-day session. I've paused and wondered if we added any additional flexibility or modernization. We certainly provided greater public input through this process, and I think that's really a good thing. But we also, in many ways, provided opportunities for folks with various interests to throw wrenches in a process moving forward. And I think it's just indicative of what challenges we face as we consider any changes to the CON statute. I think we have more opportunities when it comes to the regulation as we have more direct authority, but our authority is much more limited in terms of what we can do through regulations. So,
Ben, you want to go to?
Yeah, looking forward to next month, we do have plans to bring forward for informal comment the state health plan chapter for organ transplant. That has a work group's been meeting for almost a year now. We think we can bring that forward. We'll have a report from our all-payer claim database group on the privately insured. That's a legislatively required report. We'll also have several MCDB, APCD data releases, one to the Lewin Group. They will be using the MCDB for their evaluation of the all-payer model under contract to CMMI. We'll also be bringing forward a request from the University of Maryland School of Public Health for use of the MCDB. We'll have some additional the fourth round of telehealth grants, and we should also expect that there will be at least one CON application for you to review. There are several that are almost ready, but we're sort of looking at last-minute challenges before we indicate which one's going to be before you on your agenda for May. We will also be looking to hold a half-day retreat at the June commission meeting. Likely it will be off-site and would begin early in the morning, continue till approximately 1 or 1:30, and then we would convene our normal June commission meeting at about 2 o'clock, with hopefully it being abbreviated that day.
And then in light of the time today, we will have the 2 work group meetings. We'll try to make that to be a phone conference meeting sometime this next week, and we'll just work out scheduling in the next day or so. And if there's no other business, I'll entertain a motion to adjourn. Second? All in favor? Aye. Meeting adjourned.